Welcome to The Explainer. We're jumping right into what is essentially a high-stakes medical thriller today. We're going to track a perforated peptic ulcer literally minute by minute. We'll start from the exact second the stomach's defenses cave in, ride out the ticking clock of systemic shock, and scrub in for the highly choreographed surgical rescue. If you've ever wanted to really understand the sheer, terrifying precision required in acute care surgery, well, you're in exactly the right place.
Now, I want to hit you with a number right out of the gate. 70%. Look, millions of people walk around with basic peptic ulcers, right? They pop an antacid, tweak their diet, and they're totally fine. But the second that ulcer decides to go from a surface scratch to a full-blown through-and-through hole in the stomach or duodenal wall, the rules completely change. Full perforations account for a staggering 70% of all ulcer-related mortalities. That's a massive number. Even with all our modern medicine, this is a drop-everything, life-threatening emergency. Which brings us to our first section. Anatomy of a breach. How exactly do the stomach's incredibly tough natural defenses just collapse?
Let's look at the main saboteurs here. First up, we've got the infectious driver, H. pylori. Now, this isn't some passive little bug. It's actively destroying tissue. It actually uses an enzyme called urease to pump out ammonia, which neutralizes the stomach acid right around it so it can survive. Pretty clever, right? But that whole process sets off a massive immune response that literally digs a deep, penetrating crater into the tissue. Then, on the flip side, we have our pharmacological drivers. Think everyday NSAIDs, like your standard ibuprofen. Instead of actively attacking, NSAIDs are stealthy. They silently shut down the stomach's defense systems by inhibiting the COX-1 enzyme. That makes your protective prostaglandins just plummet, leaving the stomach lining totally naked and defenseless against its own acid. So you've got an active attacker on one hand and something that secretly disables your shields on the other.
And that brings us to section 2, the ticking abdominal clock. Because once that wall is breached, time is absolutely not on our side. We are looking at a terrifyingly precise descent into systemic shock here. In the first 12 hours, zone 1, the patient suffers a massive chemical burn from the stomach acid spilling out. Now, surprisingly, that environment is actually sterile at this point, but the acid causes massive, violent fluid shifts in the body. Then we hit zone 2, from 12 to 24 hours. All that fluid the body rushed in to dilute the acid, well, it inadvertently neutralizes the whole area, turning it into a perfect, cozy breeding ground for bacteria like Streptococcus. And if we cross that 24-hour mark without fixing it, we're in the ultimate danger zone. Bacterial endotoxins flood the bloodstream, triggering a massive inflammatory cascade, multi-organ failure, and eventually death. But here is the wildest, most deceptive part of this whole timeline. Right in the middle of phase 2, between 2 and 12 hours, the patient often goes through what doctors call the illusion of recovery. The excruciating, stabbing pain from the initial blowout suddenly just fades away. Why? Because the escaping acid is getting diluted by the body's own fluids. The patient genuinely feels better. But guys, it's a deadly trick. Beneath the surface, the abdomen is becoming incredibly rigid, literally board-like. And you'll often see something called Valentino's sign, where fluid tracks down the right side of the belly, perfectly mimicking appendicitis. That brief sigh of relief, it's just masking a silent bacterial invasion.
So, section 3, racing to diagnose. We have to spot this breach before it's too late.
With that clock ticking down, finding the exact location of the breach quickly is literally the only way to save the patient. But we run into a really dangerous diagnostic trap right here. How can we be absolutely certain we're looking at a lethal perforation and not just some harmless imposter?
Check out this stark contrast. On one hand, you have true pneumoperitoneum. That's the real deal, the shock-inducing perforation. On an X-ray, you'll see this smooth, unmistakable crescent of trapped free air right under the diaphragm. That means get them to the OR right now. But then, look at the mimicker, Chilaiditi sign. It looks really similar at first glance, but it's just a harmless loop of bowel that managed to slip up between the liver and the diaphragm. If you look closely, the mimicker has distinct haustral folds, basically the natural bumpy texture of the colon. Imagine misreading that X-ray. You'd be rushing a perfectly healthy patient into a catastrophic, entirely unnecessary open abdominal surgery. Yikes.
Actually, the most important thing during diagnosis is knowing exactly what not to do. There is a strict, non-negotiable contraindication here. You cannot, under any circumstances, use an endoscopy, an EGD, or barium contrast. Think about it. If you pump air into the stomach to look around with a camera, you're going to literally blow the body's fragile temporary protective seals completely apart, blasting even more acid into the abdominal cavity. And if you force barium contrast down there,
It leaks through the foal and triggers an irreversible, brutal peritonitis. Using standard diagnostic tools right here is literally adding fuel to the fire.
Okay, Section 4, immediate medical defense. How do we stabilize them for the fight ahead?
The second we confirm the perforation, it's go time. We launch a hyper-aggressive choreographed defense protocol, and we have to do it in the first hour. Step 1, hemodynamic resuscitation. We are pumping aggressive IV fluids to keep the blood pressure from crashing and to keep the organs alive. Step 2, gastric decompression. We drop a large tube down the nose straight into the stomach to physically suck out the acid before it can spill out the hole. Step 3 is profound acid suppression. We hit them with high-dose IV meds to completely shut down the stomach's acid factories. And Step 4, a massive, broad-spectrum antimicrobial strike to wipe out the bacteria throwing a party in the peritoneal cavity.
Moving to Section 5, the surgical rescue operation. It's time to scrub in.
If the patient is still spiraling, the surgeons have to physically go in and patch the leak. And honestly, the way they do this is so incredibly clever. You can't just stitch the edges of an ulcer together. The tissue is basically mush. It would just tear right through. So instead, they use a vascularized omental tongue. Essentially, they borrow a piece of the patient's own healthy, blood-rich belly fat, the omentum, and literally plug it into the hole. Now, the old-school 1937-gram patch just used a detached piece of that fat. But the modern evolution, the modified Selin-Jones technique, keeps that fat attached to its original blood supply and uses an entirely separate set of sutures. It optimizes the healing process and massively drops the chance of the leak reopening.
But what if things are totally sideways? Say the surgeon opens up the belly and finds a massive necrotic ulcer, like over 3 centimeters wide, and the patient has been deteriorating for well over 24 hours. A simple patch isn't going to cut it. The tissue is entirely dead. That's when they pull out the ultimate surgical bailout, triple tube drainage. Just look at this complex plumbing. They drop one tube to decompress the stomach, thread a second one backward into the duodenum to create a controlled external fistula, literally giving the leak a safe highway outside the body. And then thread a third tube way down to the intestine just to feed the patient. Instead of risking a new patch blowing out in a highly infected abdomen, they control the chaos. This rig stays in place for 3 to 4 weeks, buying the body the time it needs to heal itself.
And finally, Section 6, eradicating the threat. Because the battle isn't over when they leave the OR. So we survived the surgery, stopped that ticking clock, and stabilized our patient. But guys, this explainer isn't quite over yet. There's this incredibly chilling detail straight out of the clinical guidelines. 6 to 8 weeks after the patient goes home, there is an absolute, non-negotiable requirement for them to come back for a follow-up endoscopy. Why? Because after everything, the sudden agony, the shock, the emergency surgery, the crazy abdominal plumbing, the doctors have to go back in with the camera to biopsy that exact spot. Because this whole catastrophic ordeal might have just been the very first symptom of a much more sinister hidden villain, underlying gastric cancer. It kind of makes you wonder, right? If a microscopic breach can cause your entire system to crash in just 24 hours, what other silent invaders are lurking just beneath the surface, just waiting for their moment to strike?